All right. Good morning, everyone. How are we doing this morning?
Good morning, Dr. Hall. I am fine, and I guess we are all fine.
You're speaking for the class. You guess you're all fine? Okay. Hi, Ernesto. Hi, Jessica.
Good morning.
Good morning.
All right. So since getting my kid, hey, Jesse. Hey, Jose. Hey, Yvonne. Since getting my kid out in the morning, because it's 7 o'clock here, is like an Olympic sport, I didn't have time to check the quizzes to see how everybody did. So we're going in blindly here. Yeah, he only wants to hug me when I'm getting ready to sign on to a Zoom, and it has to be like the longest possible hug ever. Other than that, he's pretty stingy with his hugs. So today we're going to go through the case questions that you had to do for homework. I have Jeff Wargo here. He is a fourth year APPE student on rotation with me. And so he's going to be going through the cases with y'all today. He's doing an academic rotation. It's an exploring pharmacy practice rotation. So he's working with me and Dr. Bailey and Dr. Moody. We have a lot of teaching going on. He's doing ID with Dr. Bailey. We're kind of skipping the managed care stuff because I'm doing a lot of teaching, so I'm not doing a ton of stuff at my practice site. So please give him more respect than you give me. So I would really appreciate if you turn your cameras on so that he's not talking to a black hole, especially if you're somebody who doesn't typically have your camera on. When you're responding to questions from him, please respond privately to him or to the whole group chat. He is the teacher today. I'm just here to fill in any gaps. All right, so I only see 4 students on camera. So if the rest of you could turn your cameras on, unless you have an extenuating circumstance on why your camera can't be on, I'd really appreciate it. Imagine how you would feel if you were giving a presentation that you worked on. Although Jeff's probably like, no, leave your cameras off. I don't know. All right. So without further ado, I'm going to turn it over to Jeff.
Hello, everyone. So again, I'm Jeff, and I'm just going to kind of go over your quiz questions from yesterday. So if I'm just going to share my screen here. Hold on. Can everyone hear me? Okay.
Yes, we can hear you, and we can see your slides in presentation mode.
Okay. So again, this is peptic ulcer disease, IBS, and nausea vomiting cases from your quizzes yesterday. First question was, so I'm just going to read off the questions, and then, like Dr. Hall said, if you guys could just either direct message me or send your responses. First, we're going to go over the case question and then kind of go over any of the factors that could have contributed to your decision-making process of which choice you made. So the first one is 45-year-old patient diagnosed with H. pylori, H. pylori resistance to clithromycin in area is less than 10%. Patient's home medications include simvastatin, 40 milligrams PO once daily, lisinopril 20 milligrams PO once daily, azithromycin 500 milligrams PO on day 1, and then 250 milligrams daily for 4 days. Patient is on day 5, so they're pretty much done that regimen. And then the question is, what treatment regimen for H. pylori do you recommend? So first, we're going to kind of go over the factors that you looked at as far as how you chose which response, like which answer you chose. So can anyone want to?
I chose the bismuth quadruple because the first one, the concomitant one, is like third line, but the clarithromycin triple on our slides, it says avoid in patients with recent use of macrolide, and they just were on the azithromycin.
Okay. Perfect. So I'm trying to find that. Okay, so like you said, the patient was just on azithromycin, so that's a macrolide, just like clarithromycin. So when a patient has just finished a regimen on azithromycin, you wouldn't want to give them clarithromycin again. So the only option there that doesn't have clarithromycin is option B, the bismuth quadruple. Bismuth quadruple regimen is a first-line treatment option for H. pylori. Again, it doesn't include the clarithromycin, therefore avoiding the risk for resistance. Also, clarithromycin has a drug interaction with the simvastatin. So the patient taking the 40 milligrams simvastatin daily. So you wouldn't want to give them that or any regimen that includes clarithromycin. So perfect.
Quick question. So it's saying that the power resistance to the clithromycin is less than 10%. So as far as the resistance, it should be good, right? Because if it's more than 15% is when we don't use clithromycin. But in this case, it says it's less than 10%. So, I mean, I get that, it might interact with the simvastatin, but I guess this statement here was just kind of confusing. So that's why I chose the C, which is the concomitant one. But I don't know. I mean, it was just kind of confusing there.
So do you want to answer that, Dr. Hall?
Sure. So, or is there another student that wants to explain to Dagmawi why resistance is a factor, even though the resistance is less than 10%?
Yeah, I would just like to add that the guidelines says clearly that even when the resistance is greater than 15%, if the patient has been exposed to another macrolide, we should avoid giving them that regimen. So that's why in this case we didn't go for either of the regimens that had clarithromycin, which is another macrolide.
Thank you so much, George. Yeah, so and I didn't mean to single Dagmawi out because I'm sure there's other people that have that same question, because the slides clearly say resistance less than 15% that is okay to use, but the patient has been exposed to a macrolide. Azithromycin is a macrolide. And so that increases the risk of resistance despite the resistance of less than 10%. So that's why we can't use anything with clarithromycin, because they are currently on day 5 of azithromycin. So that can increase the resistance to clarithromycin.
Okay, thanks.
So when you're looking at regimens with clarithromycin, you need to look at the resistance rate. And as Doug Maui said, less than 15% is what we're aiming for. You need to look for drug interactions. And you need to look for other macrolide exposure to determine whether a regimen with clarithromycin is appropriate. Right? Does this sound familiar? So think about that for all the, oops, I have to clean the screen, but think about that for all the regimens. What would prohibit you from using metronidazole?
Alcohol use,
Yeah.
allergy. For the patients that have allergies to penicillin.
So that would be a reason we would use metronidazole if a patient was allergic to penicillin. Which drug could we not use if they had an allergy to penicillin?
Amoxicillin.
Yeah. And what about tetracycline?
Children,
I'm sorry, what
I said children,
okay,
not
children.
even children.
Anybody else?
Pregnant people.
Yeah, pregnant people. All right. So when you're looking at a case, you'll see a case similar to this on the exam. I just did the questions yesterday. So when you're looking at a case, these are all the things you're looking for. You're looking for the clarithromycin resistance. You're looking for recent macrolide use. You're looking for penicillin allergy. You're looking for alcohol use. You're looking for if they're a child or pregnant to help determine which of these choices are the best. And these choices here are the first line treatments. If you see any other regimen, those are not first line treatments, and we should not be using those unless there's a clear indication. Any questions on this? I do have one more question. Can we switch out tetracycline for doxycycline or minocycline? Can we switch out amoxicillin for cephalexin?
No.
Say it loud and proud.
No.
No.
No, we cannot switch out anything. It has to be these exact regimens. Okay. And I'm not going to ask you on the exam concomitant or bismuth quadruple or clarithromycin triple. All the agents will be there individually. Got it. Got it. All right.
Okay. So next question, 68-year-old patient with hypertension, hyperlipidemia, diabetes, osteoarthritis, and patient's current medications are losartan, 100 milligrams daily they've been on this for 5 years, atorvastatin, 40 milligrams daily. They've been on this for 3 years. Metformin 1,000 milligrams daily for 3 years. Naproxen 500 milligrams twice daily for 1 year. Patient diagnosed with gastric ulcer. What treatment regimen do you recommend? Okay. So the options were pantoprazole, famotidine, sucralfate, misoprostol. So looks like most of you said A. Pantoprazole 40 milligrams PO daily. So just from the patient's case, they most likely have an NSAID-induced ulcer due to age and chronic use. So you wouldn't want to give them, I'm sorry. So yeah, famotidine is a histamine receptor antagonist. So they are not recommended for treatment-induced, for NSAID-induced ulcers. Sucralfate forms a physical barrier over an open ulcer to help decrease the symptoms. However, it does not promote healing of the ulcer. And then misoprostol is used to prevent NSAID-induced ulcers. So it's not recommended for the treatment of NSAID-induced ulcers. So yes, pantoprazole, which is a proton pump inhibitor, is usually a preferred treatment for NSAID-induced peptic ulcer disease because they provide a more rapid symptom relief and promote ulcer healing. Looks like most of you guys got that right. Did anyone have anything different?
Yeah. This was a tricky one for me because the patient had a history of hyperlipidemia, yeah, and hypertension. So I definitely eliminated misoprostol. For the famotidine, of course, was not an option. Pantoprazole, however, I see the patient also had a history of osteoarthritis, and this is a 68-year-old patient. And I know this can further promote like osteoporosis. So I went for sucralfate. I just want if I don't know if Dr. Hall can explain better why pantoprazole was preferred over sucralfate in this case. Especially with the patient having osteoarthritis.
So yeah, these other comorbidities were kind of just put in there to try to trick you guys into other options, but really the misoprostol, it can be used to for NSAID-induced ulcers, but it's used to prevent, and it's not recommended for the treatment. So yeah, I'm not sure if Dr. Hall can try to, or if anyone else can try to. Ernesto?
I think sulcrafate is just it won't, it's like a, I wouldn't say adjunct, but and correct me if I'm wrong, but it won't like do something to the ulcer directly. It just like does like a coating, so it won't treat the underlying disease or like promote healing of the ulcer.
Yeah, I was gonna say with Ernesto, I feel like the Carafate is kind of just like a Band-Aid. It's not gonna promote actual treating the ulcer and preventing, well, not preventing it from happening again, but just actually completely eradicating the ulcer.
But sucralfate forms a coating on the ulcer so the ulcer can heal. My only issue is the patient has a history of osteoarthritis, and PPIs can further promote that. So are we giving the patient a PPI in this case?
George, what is osteoarthritis?
I would say like bone pain.
Yeah. So it's like joint pain in your knees, in your elbows, and your hands, and your wrists. I think you're getting osteoarthritis confused with what do you think Does somebody have an idea of what George might be confusing osteoarthritis with?
Osteoporosis.
Yeah, osteoporosis. So osteoporosis is when we have bone loss because we're not getting enough calcium, vitamin D, weight-bearing activities. And you're right, if this patient had osteoporosis, we would definitely have to think about our choice, but of treatment. But even if the patient did have osteoporosis, pantoprazole would be still the treatment of choice for an ulcer that is likely due to naproxen or NSAID, because the risk of the patient bleeding from that ulcer is greater than the risk of that patient having a bone break from osteoporosis. So be careful what you're reading and making sure you understand this is osteoarthritis, so that's pain in your joints. Osteoporosis is fragile bones due to decreased calcium and vitamin D absorption and weight-bearing activities. All right, but even if they did have osteoporosis, the treatment of choice would still be pantoprazole because it quickly increases the pH of the stomach, stabilizes that ulcer, and prevents a GI bleed. A GI bleed will kill you today. Osteoporosis may or may not kill you, and especially if you don't have a fall.
The explanation really helps now. Yeah, I get it.
Okay, great. What other questions do you all have on this? All right, thank you.
Okay. Next question.
Sorry, Dr. Hall.
Yes.
This use of misoprostol, when does it become like a must use?
So misoprostol is for the prevention of NSAID-induced ulcers. So it would be we would use that in a patient, or I guess, can somebody tell me when we would use misoprostol? Do we use it for all patients on an NSAID?
No.
No, okay. So how do we differentiate the patients who need misoprostol with their NSAID and patients who don't need misoprostol with their NSAID?
Moderate to high risk patients?
Yeah, moderate to high risk patients. Is that you talking, Jesse?
Yes.
Okay, thank you. Yeah, so it would be patients that are moderate to high risk. So patients who are greater than, I think, 60 or 65, patients who are on a non-selective NSAID, or patients who have a history of peptic ulcer disease, patients who are on an anticoagulant. So you do need to know your anticoagulants: apixaban, dabigatran, rivaroxaban, aspirin. Those patients would need misoprostol with their NSAID. You need to figure out which NSAID. You need to know which NSAIDs have less COX-1 inhibition, okay, and which ones are COX-2 preferential, because that will also help you determine when you need misoprostol, or which agent is best for a patient who is moderate to high risk. All right, and then as Jessica and Ernesto pointed out, sucralfate is an adjunct. It just coats the ulcer so that the patient can eat. It's not doing anything to heal it. It's just preventing symptoms and pain when the patient is eating. It's like slapping a Band-Aid on the ulcer. And all of a sudden, my kid is really into Band-Aids, and they don't stick very well. So the sucralfate has a very short half-life. It's going to help when the patient eats, and then it's going to wash away and not be very helpful. All right. Famotidine has a short half-life and is a reversible H2RA inhibitor. It does not increase the pH of the stomach, so it's not going to promote the stability of the ulcer and is not going to promote the healing of the ulcer as well as a PPI. Okay. What other questions do you have on NSAID-induced ulcers? All right, you can keep going, Jeff.
Okay. So next question. Patient with a history of peptic ulcer disease presents to emergency room with hematemesis and melena. Patient's hemoglobin has dropped from baseline of 10 to 7. Patient is pale and fatigued. What is the most appropriate treatment for this patient recommendation? So first, we got to look at what the patient is in the emergency room for. So hematemesis and melena, and their hemoglobin has dropped. Patient is also pale and fatigued. So we have to really get down to what the active problem is. So it looks like almost everyone said B. Pantoprazole 80 milligrams IV bolus followed by continuous infusion. So the patient is suspected or found to have an active bleed, GI bleed. So they should be started on a proton pump inhibitor. And the bolus is going to kind of get the ball rolling and help the GI bleed. So, and then followed by the continuous infusion for 72 hours. It's the quickest way to increase the gastric pH for this patient, and it promotes hemostasis and clot stability. So what we're looking to do is just pretty much stop the bleed.
What in this case tells you that the patient has an active bleed?
Melena and hematemesis.
Okay. What are the lay terms for melena and hematemesis? How would you describe that to a patient?
Blood in the stool.
Okay, great. Blood in the stool is the melena, is more of like a dark tarry stool. What is hematemesis?
Vena blood.
Oh,
I'm sorry?
oh.
Vomiting blood. Vomiting blood.
Vomiting blood. Okay, thank you. Yeah, so vomiting blood. Emesis is going up. Heme means there's blood in your throw up. All right. And the patient has a hemoglobin drop from 10 to 7. That is huge. Anything greater than 1 is a huge drop in your hemoglobin. The patient is pale and fatigued, and they have a history of peptic ulcer disease. So all these things tell us that the patient currently has a bleeding ulcer. And the way we stop the bleeding is we get that pH up as soon as possible in the stomach, because a higher pH is going to stabilize the blood clot to prevent it from bleeding more and promote the healing. Remember that if we're using a PPI, especially orally, this is not going to take full effect until 3 to 5 days. Famotidine, regardless of whether it's IV or PO, is not going to decrease or increase the pH because it's reversible. It has a short half-life. We are seeing the IV BID used more and more, but the guidelines still recommend a bolus followed by a continuous infusion because we can saturate those proton pumps and get them shut off a lot faster because the drug is going directly into the bloodstream. All right, and given a chance to work. So the guidelines still recommend an IV bolus followed by a continuous infusion for an active GI bleed, because it's the fastest way to increase the pH. What questions do you have on this? All right.
Question, 75-year-old patient admitted to hospital with severe sepsis, which has caused most of the patient's organ systems to fail, including kidneys and the lungs. Patient was transferred to the ICU 2 days ago, after having to be intubated and are currently unable to come off the ventilator. What do you recommend for stress ulcer prophylaxis? So first, what do you guys think we have to take from this case question and consider when answering the question?
Age and organ failure.
What was that?
The age of the patient and the organ failure.
Okay. Yes. Anything else?
The patient is in the ICU.
Okay, great.
We're also thinking of prophylaxis here. So the patient doesn't have an active ulcer. So whatever we are going to give to this patient is something that we are giving because we don't want him to this ulcer.
Okay. So option A, not indicated. So the patient is critically ill. They're in the ICU. They've been mechanically ventilated for 48 hours. So we definitely need something to for the stress ulcer prophylaxis, something to prevent that. Famotidine. So given the patient's age and reported renal function, histamine receptors antagonists, they're not a good option due to the risk of delirium and cognitive impairment. So that is likely not a good option for this patient. They are, their age, they're older. So giving them that medication it's definitely a high risk for them. And then the pantoprazole. So again, a proton pump inhibitor would be the best option for this patient. Do you guys have any questions about that? Looks like most of you said pantoprazole. So. IBS. First IBS question. 28-year-old transgender woman with IBS-C presents with worsening constipation, abdominal pain, and bloating. Patient is currently taking Docusate, however, does not want to take Senna due to it worsening cramping and urgency. Patient does not like the taste of fiber supplements and is worried about polyethylene glycol causing diarrhea. Patient denies vomiting, blood in the stool, or tarry stools. Which medication would you recommend to help with the patient's constipation? So what do we consider first in this case to help us make a decision?
She doesn't want, like, I would write off, eliminate Bisacodyl because she's complaining of another motility stimulant, which is a Senna, right?
Right. So Bisacodyl is a stimulant laxative, which works similarly to Senna. So the patient doesn't want Senna due to worsening cramping and urgency. So the Bisacodyl would have a similar reaction or adverse reaction. What else? So we can cross that one out. What else would we consider in the case of making a decision? So why would we not choose Elocitron?
Because the patient denies vomiting.
The patient what? I'm sorry.
Because the patient denies vomiting.
So the patient is a transgender woman, so they're a biological male. So this patient, so do you guys know, can anyone tell me what IBS-C stands for?
The C is constipation. And of course.
So also Elocitron is approved for women with IBS diarrhea. So you wouldn't want to give them a medication that helps with diarrhea for someone who has constipation. So that would not be a good option for the patient. And so it looks like most of you guys said linaclotide. Why would we not choose lubiprostone?
Because the lubiprostone is for patients assigned female at birth.
Right. So it's approved for biological women, so assigned female at birth. And it is for IBS constipation, but the patient is a biological male, so they would not that would not be indicated for them. So linaclotide is approved for IBS constipation in males and females. So that would be the correct answer.
I want to go back to the comment about the Elocitron not being used because the patient has nausea or does not have nausea or vomiting. Remember that this gets a little tricky because even though it's a tron and we have trons that are used for nausea and vomiting, this is not one of the trons that is used for nausea and vomiting. Remember, this one is 10 times more potent than ondansetron. So that is way more for nausea, vomiting. So even though it's the tron, that gets tricky on the exam, right? If you're studying the names by their suffixes, you need to remember that Alistatron is for IBS-D because it's 10 times more potent than ondansetron or granzetron.
Anybody else have questions about that? Okay. Next question, 45-year-old male with IBS-D and worsening diarrhea. Patient thought the worsening diarrhea was due to having his gallbladder removed recently. However, he has been on a low-fat diet for the last 3 weeks with no improvement of diarrhea. Patient has been using loperamide as needed, but is frustrated because he is having to take it several times a day, and his diarrhea is still affecting his quality of life. Patient has developed significant anxiety related to his diarrhea and come to the doctor's office today for help. What medication do you recommend? Okay, so what factors do we consider when choosing a right choice?
Gallbladder removal.
What was that? I'm sorry.
So first keyword is the patient has already removed a gallbladder.
Yeah.
So the drug is for this is rifaximin antibiotic.
Okay. So yeah, his gallbladder was made really recently. So let's go with the wrong options first. So sertraline is an SSRI, can help the patient has anxiety, but this will often worsen diarrhea. So especially when first being started, so that would not be a good option for this patient. Aloxadoline is a tricyclic antidepressant, which can help this patient, but due to the
Exodoline is not, sorry, Jeff, exodoline is not a tricyclic antidepressant.
oh, I'm sorry. I don't know what it is then.
Can somebody tell us what exodoline is and why it's not the correct answer? Go ahead, Ernesto.
Yeah, I think it's a mu opiate agonist, and you cannot give it because it's contraindicated with patients that does not have a gallbladder. It can lead to, like, I think, pancreatitis or.
And is it for IBS-C or IBS-D?
It's for IBS-D.
Okay. But we can't use it in this patient because this patient doesn't have a gallbladder. Okay, continue on, Jeff.
Okay. So Olocitron is approved for women with IBS-D. The patient's a male, so that would not be indicated for him. And then rifaximin, which I believe most of you chose, is approved for men and women with IBS-D. So that would be the right answer.
I have a question. Like, would be like rifaximin is quite expensive. Like, would that be like a factor that we would use like in terms of insurance and like for the patient?
Yes, but while it can be expensive, it's probably the most, I don't really know how to answer that because it's not really something that you think about you think about it, but in a clinical setting, but for this class, it's kind of not what you want to think about right now. Do you have anything to add, Dr. Hall?
Yeah, you're exactly right. We would think about it in the clinic. We would not think about it in this class on an exam because there's no other choices here. But also remember, when we're in the realm of IBS, all the drugs are really expensive. So even though when we were talking about rifaximin as it relates to maybe C. difficile, where we have like PO Vanco is super cheap compared to rifaximin, or super cost effective. I need to change my language. Super cost effective, so low cost, high value. Metronidazole is low cost, high value for C. difficile compared to rifaximin. When we're talking about hepatic encephalopathy, lactulose is low cost, high value compared to rifaximin. So in those disease states, we have other drugs that are low cost, high value, meaning they don't cost a lot and they're very effective. For IBS, all these drugs are really expensive. And so we should take it into consideration if we're working in a GI clinic or we're working in a primary care clinic trying to help get these patients the medicine. But for the sake of the exam, there's no other choice here of these choices that is reasonable. So it would make that the best choice. But that's a great question, Ernesto, because it is a little bit different than what we talked about for hepatic encephalopathy and probably what you talked about for C. diff last semester.
Thank you.
So, Dr. Hall, in the hospital setting, when we have a patient who cannot afford rifaximin, in this case, what would be the option for the patient?
So this patient, this patient isn't in the hospital, but if they were admitted to the hospital, if rifaximin wasn't on the formulary, we would have the patient maybe bring it from home to use their own home medication. It wouldn't be a medicine. It's not an acute medicine. It wouldn't be something that we start in the hospital. It'd be something we'd start as they're leaving the hospital. And then that would fall on whoever takes care of them outpatient to get the prior authorization. But rifaximin is not a hospital medication. But if they come into the hospital and they're sick and they still need the rifaximin, we would either follow our formulary to get it or we would have the patient bring it from home. But IBS is if IBS is not an acute disease, meaning that typically patients are not in the hospital for their IBS symptoms. Doug Maui, did you have another question?
Yeah, so my question is, this patient, it looks like he had like a persistent diarrhea. So a rifaximin, isn't it for like a short relief as opposed to like, for a patient that have like a persistent diarrhea? So we use that for like a short relief. So, I was just wondering why we're using this when the patient have like persistent diarrhea, and it looks like as if you have like a severe diarrhea, maybe.
Yeah, it doesn't say anything about severe. It just says worsening. So don't overanalyze the information you're being given in the case. You're right, rifaximin is used for a 14-day therapy, and it's kind of like a control-alt-delete of your gut. It's like, we're going to give you rifaximin. We're going to try and clean up what's going on with the bacteria in the gut and see if that resets your GI tract to decrease the diarrhea. So you're right, it is a short-term therapy, but we're hoping that it has long-term effects. It's, again, resetting, control-alt-delete, hard shutting down your computer, hard shutting down your GI tract to get rid of the bacteria that aren't supposed to be there. and seeing if after 14 days, your GI tract can get back on track and not have as much diarrhea. All right, so I don't want you to think of it as a short-term medicine. I want you to think of it as a chance to reset the gut, to hopefully get the bacteria back in balance to prevent diarrhea. What other questions do you have in this case?
For the next question, select all that apply. Which other patient's medication can worsen IBS-C symptoms? So metformin, you should all know that metformin, a very common side effect of metformin is diarrhea. Sometimes patients are able to tolerate it, but most of the time it does cause diarrhea. There are extended release formulations that patient can try. But most patients are unable to tolerate due to that. Amitriptyline, that is a tricyclic antidepressant, and it has anticholinergic side effects. So whenever you think of anticholinergic side effects, you want to think of constipation. I'm sure Dr. Hall has said this before: can't see, can't pee, can't sit, can't spit, can't shit. So you want to think of that whenever you're thinking of anticholinergic side effects. And then verapamil, non-dihydropyridine, and calcium channel blocker. And again, most common side effects is constipation. Colchicine is used for gout flares, and it is most commonly associated with GI adverse effects like diarrhea. So the correct options are amitriptyline and verapamil. Do you guys have any questions about that?
When you look back on your time with me, I want you to remember, I want you to always hear me saying, can't see, can't pee, can't spit, can't.
You've been vomiting. I have been nauseated and vomiting for the past week. I have felt so ill most days that I cannot go to work. I am so exhausted I can barely keep my eyes open. I took a pregnancy test yesterday and it was positive. So, what is the best option to treat this patient's nausea and vomiting? And first, what do we consider in this case to help us choose a option? Okay, so yes, pregnancy is definitely number one. Anything else?
Patient is
Yeah.
Patient is she's sick. She says she feels sick, exhausted. She can barely keep her eyes open. So we want to avoid anything that will make her feel more sick.
yeah, she's exhausted, she's very tired. So you want to avoid any medication that will kind of make that worse. So the pyridoxine and doxylamine 3 times a day. So thinking about just the doxylamine component, that is very sedating, and it's an antihistamine, and so it's the first gen antihistamine, so that component would make that choice wrong. And then promethazine. So again, the patient is very exhausted. She can't keep her eyes open. Promethazine is very sedating. While promethazine is indicated for pregnant patients, it's third line option. And so, but because the patient is so tired and exhausted all the time, that's not one of the options that you want to choose. Because that pretty much is her biggest, well, aside from nausea and vomiting, is her biggest problem. So ondansetron, while we don't see it often used in pregnancy, it does cause less sedation. So that would be the correct answer. Does anybody have any questions about that?
I'm a little bit confused about the option because it did say that the first option was like the first line, and then ondansetron is the third line. Could you explain a little bit more about why we picked this option instead of the first line?
So the patient's problem, aside from the nausea and vomiting, they're exhausted all the time. They can't keep their eyes open. So these other options are while they may be first line, they're sedating. They're going to cause the patient to feel more exhausted. So you really don't want to make the problem worse than it already is. You want to treat the problem, but you don't want to make her other issues worse. So that's why while it's not first line, you want to move down to your other options when you're looking at the whole case. Ondansetron is the best one. Does that kind of answer your question or no?
Yes, I just read the note that I saw on the doxylamine here. So yeah, I do get it now. Thank you.
This one is tricky for everybody every year because we're not using a first line agent. But remember, we have to look at the patient as a whole. And if there's a contraindication to use a first line agent, we move down the list. And so the doxylamine, as we talked about, is first generation. It crosses the blood-brain barrier. It causes sedation. So that's going to make her feel even worse. And it's going to make it hard for this patient to take it because they're going to be more tired. So we can provide, this might be first line, but it's going to be detrimental to something else the patient already has going on. So we want to move down the line. We move down to the next one in line, promethazine. A lot of data, and very effective, but I mean, I fell asleep at a NASCAR race on an oral of this. So this patient, again, is tired, exhausted, can't keep their eyes open. So again, not a great option. So yes, we did move down to the third line option as our first choice because this is less sedating and going to cause less sedation for the patient. So remember that guidelines are guidelines, and it's like what we should do if there's nothing else going on. But sometimes if there's something else going on with the patient that says like our first line is just not a really great choice in this situation. We move down the guidelines. So remember, when we're treating a patient, we take the guidelines and the evidence-based medicine and we combine it with the patient-specific factors that they have going on to find the best option there. So Jesse, you're in good company because lots of students before you have had the same question, and I'm sure there's lots of people on the call right now who have the same question but weren't willing to ask. So, or read over that part or didn't pay close attention to that part.
Yeah, I just realized what I asked actually after asking it.
Okay. Yeah. All right. Any questions on that? Now, if I were a provider, I would probably say, okay, let's try the pyridoxine, the B6, throughout the day. You take it 3 times a day, and then you just take the doxylamine at night and see if that controls your nausea and vomiting. So if I wasn't taking a multiple choice test, that's what I would do. But you're taking a multiple choice test because I don't want to hand grade all those written answers and then split hairs about who has it right and who doesn't. But that's where we can have some, when we're in practice, we can say we can still use the first line, but we can modify it a little bit. And in fact, that's what they did with me when they had me taking B6 around the clock and then just using the doxylamine at night. And then you can titrate that up. Yes, ondansetron is very much less sedating than the other, than promethazine or doxylamine. And so I think sedation is a warning on ondansetron, but overall it's not very sedating for patients.
Can I share something?
Yeah.
I think my thought process was like I assumed that doxylamine is going to be given at night and paroxetine is going to given in the morning. So I picked that as my answer. I assume that doxylamine is going to be given at night. So yeah.
Yeah, we have to be careful because these are usually, the drug is diclegis and you usually can't separate it out. And it doesn't say which one is given 3 times a day, but the way it's written, it assumes that both of them are given 3 times a day. So these case questions are designed to be a little bit harder than exam questions because we have to get you thinking about beyond the drugs and memorizing the information and how to go through them. So they are designed to be a little bit trickier and less straightforward than what you see on the exam, because otherwise, where do we teach you to think, about these? For your exam, you only have like 2 minutes per question, not enough time to go through the questions and work through them like this. So don't be alarmed if you're struggling with some of like how this is written or what I'm asking you to find in these, because these questions are much harder for the most part than the exam questions. What other questions do you have on this question, on this?
When you say that, you mean in terms of the multiple combinations, but like the things that we're learning here, like you want us to apply, like you want us to memorize the side effects, right? It's
Yes.
just that it's not, you're not gonna have layer upon layer of
Yes. There's only going to be like 1 or 2 layers on the exam, not multiple layers. Or not more than that. But yes, you should know the side effects.
Okay. Next question, 55-year-old patient with uncontrolled diabetes has been experiencing some nausea recently, especially after eating. Which medication would be the best choice for this patient? So, what parts of this question do we consider when choosing an option?
Age and uncontrolled diabetes.
Yes. Anything else?
And that they're only experiencing nausea after eating.
Okay. Yes. So, yeah, the other factors are important, but really experiencing nausea after eating will kind of help you guide which option to choose, because let's go through the options. So it looks like most of you guys said A, metoclopramide. So dexamethasone, corticosteroid, while it is used for nausea and vomiting, is used for chemo-induced nausea and vomiting. And it can also be used for prevention of operative nausea and vomiting. So this patient is experiencing nausea and vomiting after eating, so that's not the best option for this patient. Dronabinol, also used for refractory chemo-induced nausea and vomiting, or in patients um, with anorexia due to chronic diseases like HIV and AIDS. So again, this patient is just experiencing nausea after eating, so that probably don't need that medication for this. Metoclopramide is the best choice because the patient is most likely experiencing gastroparesis, which is just uncontrolled, um, you know, nausea and vomiting. And so the best results, metoclopramide should be given before or with meals. So yeah, metoclopramide is the correct answer. Do you guys have any questions about that?
So please be able to recognize gastroparesis. It's most common in patients with uncontrolled diabetes, and it's nausea that happens after eating. And so it's because uncontrolled diabetes slows down the GI tract, slows down the gastric emptying. So we need a prokinetic agent. Metoclopramide helps, is prokinetic to help move the food through the GI tract.
Next question, despite being given granisetron and dexamethasone prior to treatment, patient is experiencing nausea and vomiting after having chemotherapy. What is the best option to treat this patient's nausea and vomiting? So what options or what factors do we think about when answering this question in the case?
The medication that they were given and plus the chemotherapy part.
Right. So the chemotherapy, the nausea and vomiting is caused from the chemotherapy medication. So Also, it's important to note that the patient was given a tron and dexamethasone prior to treatment, and they're still experiencing this nausea and vomiting. So because of that, since the patient was given granasetron prior to chemotherapy, it's unlikely that ondansetron is going to help this patient because they work the same. They're both 5-HT3 receptor antagonists. So giving them that, it's not going to do anything for them. So next, a aprepitant, NK1RA, which are used for chemo-induced nausea and vomiting prevention, not breakthrough nausea and vomiting. So we're looking for a medication that's going to help the patient's nausea and vomiting or treat the patient's nausea and vomiting. So we're already past the point of prevention. The last option, which some of you chose, promethazine. It's the best choice for the patient because it works differently than granasetron and dexamethasone. It's good for general purpose antiemetic, and it is effective for breakthrough nausea and vomiting. So this is good for patients who are actively vomiting and having nausea. So while when you think about whether it can be PO, you don't want to give a patient a PO medication while they're vomiting. That's not going to work out very well. So you can give promethazine rectally and IM. So promethazine would be the best option. Do you guys have any questions about that?
I'm looking at my slides, and I'm looking at the slide on CINV. I don't see any cluster that speaks to promethazine, so I'm a little bit confused. I see 4-class I see the 5-H3 receptor, I see the NQ1 receptor antagonist, I see olanzapine, I see glucocorticoids as adjoints. Those are the only 4 boxes I see on that slide. I don't know if I'm mixing something. For CINV induced postoperative.
So can anybody explain why promethazine is appropriate in this case, even though the slide doesn't specifically say chemo-induced nausea and vomiting? Yes. Sister. Go ahead. I can't see who's talking.
Oh, I was gonna say that like Kingsley, I also had the same thoughts about like the chemo part of the patient for treating the chemo. But then from what you said earlier and from what Jeff said, like I realized that we are actually just treating the nausea and vomiting. Like it's not like specific to like, oh, chemo induced or like yeah. But right now just focusing on like the nausea and vomiting.
Okay, so it is still chemo-induced, but you're right, it's become a little bit more complicated than chemo-induced at this point because they've been giving treatment that's specific to chemo-induced. Jose Yvonne, did you have something you wanted to add?
I was gonna say that I don't know if Kingsley had an issue with this, but the breakthrough was a keyword for me. Like you're already treating the vomiting that started.
Okay, so a keyword for Jose Yvonne was the breakthrough. Okay, Ernesto, do you want to add anything to the conversation?
Yeah. Yeah. As like as Jose said, it's breakthrough and also a re, a pre a prepient whatever. I'm sorry. A prepitant, I think, is for prevention. So I think if we give it that to the patient is already actively vomiting, so it won't work. And we already gave it, like everybody said, we already gave a Tron, which did not work for the patient. So yeah.
Yeah, I also just wanted to add, I went for Dancitron, but also after getting the explanation, yeah, it makes sense. But what I'm not sure is if the effectiveness of, even though they're the same class, I don't know if they have the same effectiveness, Guanicitron on Dancitron. I would just love clarity on that.
Yeah, so I'm not sure. Grancitron is the like new sexy on Danzitron. Kytrel, I don't know how to explain it. When it came out, they tried to say that it was better than on Danzitron. I haven't seen any head-to-head studies. Maybe I should look at something like that for CRD Journal Club or in the future. But if you have something working on one mechanism of action, you don't want to hit that same mechanism of action again, even if you think it might work better. Promethazine, even though the slides don't clearly say chemo-induced nausea and vomiting, it says it's good for breakthrough. It says it's good for refractory. It is the workhorse of nausea and vomiting. Basically, if nothing else works, like promethazine is probably going to work. Remember, it also works when the patient is actively or actively vomiting. So just because it doesn't say that it is used in chemo-induced nausea and vomiting doesn't mean it's not used. So the ones that say chemo-induced nausea and vomiting, that is primarily where they are used. But just because it doesn't say chemo-induced nausea and vomiting doesn't mean it can't be used. Promethazine is a workhorse of nausea and vomiting, y'all. All right. So this patient has, out of these choices, the only thing that's probably going to work for this patient is promethazine based on the mechanism of action. Does that help with that? All right, so remember, the slides are just the cliff notes. You have to clearly understand what breakthrough nausea and vomiting means. You have to clearly understand what refractory means. People who have chemo-induced nausea and vomiting can have breakthrough and refractory. So, please know that not everything can be put in the slides. You have to have an understanding about what breakthrough means, what refractory means, and that patients with chemo-induced nausea and vomiting can have breakthrough and refractory. And if that's the case, then we can use those other agents that aren't specific for chemo-induced nausea and vomiting. So try to think beyond just the words on the slide. Try to think about what they mean and how they apply to patient cases.
Wouldn't sedation would have a problem with this? I mean, the patient would extremely be sedated if we use promethazine, correct?
Potentially, but there are no other choices here that are good. So you have, like, what is the best choice out of the three choices you were given?
Okay, thanks.
Yep.
Okay. So this was the bonus question in your quiz. We're going to compare histamine receptor antagonists with proton pump inhibitors for peptic ulcer disease. So first you want to start critically thinking about what factors to think about when you're comparing histamine receptor antagonist to PPIs. So first, why would we use a PPI versus a H2RA for H. pylori and NSAID-induced peptic ulcer disease? And then consider peptic ulcer disease bleed. Think about mechanism of action of the drugs chosen. Think about the pathophysiology of diseases, and then think about complications of these diseases.
Oh, you're asking for.
What was that?
Do you want us to give us our thoughts already?
Hold on. Yeah, if you guys, I don't know how you want to do that, Dr. Hall. If you guys wanna, I was just kind of gonna go and throw it, but
I think it would be best to hear what the students think and then go through it.
okay.
So, I had in mind, for what I remember, it was touching class already. The longer lasting and stronger potency of PPIs allow for a better healing of the ulcers, as opposed to an H2RA like famotidine that you would not have as strong of an effect, and also you do not have that continuity. So like I would be thinking about the treatment and having to all the time like getting a peak of the dose and then having to re-dose that patient all the time. So you want the continuity for the ulcer to have the chance to heal. I remember there was something else about the additional effects, but I cannot recall of the PPIs helping in other ways. But that was the one that I could remember.
Okay. Yeah, so when we think about the mechanism of actions for PPIs and H2RAs, PPIs last a lot longer than H2RA. They bind irreversibly. So whereas H2RAs, they only bind they're short acting, they only bind for a short amount of time. The target is also different for PPIs and H2RAs. H2RAs bind competitively block histamine H2 receptors. So while the PPIs will kind of, and we'll get more into this on the next slide, but PPIs stop the other factors of acid secretion. So H2RAs are less potent, they're shorter lasting compared to PPIs, and tolerance also can be developed with prolonged use and reducing the efficacy over time. So PPIs are most effective also at raising a gastric pH than H2RAs. So then we think about the patho. Does anybody else want to give their input as far as thinking about like the pathophysiology of the diseases? Renato?
Yeah, I put like that PBIs are more potent in the sense that they directly inhibit the proton pump. H2RAs indirectly like inhibit the acid release, so and they're also longer lasting, and that will make like the the acid environment less, and also H. pylori needs a neutral environment to survive because of the urease. And if you give something that suppresses acid more, it will eradicate better the H. pylori and make in combination with the other eradication regimens.
Right. So,
And I had a second thought about the mechanism of action. If I am not mistaken, antihistamine is one of 3 types of receptors that stimulates the acid release. So in HPI, you're treating one of them. There's still 2 more types of receptors that are not going to be hit by the antihistamine antagonist, like by the H2RAs. So yeah.
yes. So, like I said, there's other, I was gonna go into the next slide that really illustrates what you're talking about. So the H2RAs only hit one pathway as far as the 3 that um, create that acidic environment. So whereas the PPIs will block all 3 of those pathways, so again, back to the pathophysiology. So go back. Increase damaging factors like gastric acid. So that's the biggest factor that increases. And then pepsin, NSAIDs, which decrease prostaglandins, and then H. pylori, which secretes ammonia. When you think about the pathophysiology, you also think about the decrease of protective factors like bicarbonate, mucosal regeneration, prostaglandin, and decreased mucus. So increasing damaging factors causes ulceration in mucosal lining. So that is one of the biggest things you need to consider is this can lead to GI bleeds, increase of bleeding from the ulceration. The goals of peptic ulcer disease treatment, prevent further mucosal damage, stabilize also ulcer and mucosa, which is preventing the complication like a GI bleed. And you think about how we can achieve this treatment. First, you're going to decrease the gastric acid secretion, which can lead to increased gastric pH, stabilize ulcer mucosa, and then preventing complications like GI bleed. So here's the illustration I was talking about. The H2 receptor is just one pathway to the proton pump, and then increasing gastric acid. There are these 2 other pathways. But we only have the proton pump inhibitor that can kind of stop if you look at it as a funnel, it can block that proton pump and block all 3 pathways, whereas a histamine or H2 receptor antagonist can only block the one pathway. So I don't know who that was earlier, but that's pretty much what they were talking about. Did you have anything to add, Dr. Hall?
No.
What was that? No.
No, I don't have anything to add.
So again, the H2RA receptors, they attack only one of the three mechanisms that create gastric acid. They are reversible. So they only bind for a short period of time. They're short acting, and they work fast. Again, short duration of action. Whereas PPIs stop the final step of acid production. So no matter how it was initiated, gastrin, histamine, acetylcholine, those three pathways, the pumps are stopped. So again, the H2RAs only stop one mechanism, whereas the PPIs stop all three. So bottom line is PPIs are preferred. They are gonna work better, and they're the choice. And then yes, irreversible inhibition. So they kind of stop the PPI or the proton pump for the life of the proton pump. So they're going to inactivate it and bind irreversibly. PO form can take a while to work, but work for the life of the proton. So long acting proton pumps are long acting. That's it. Does anybody have any questions?
What questions do you have for me? All right, well, thank you, Jeff, for presenting this. I really appreciate you putting this together for the students, and thank you to the students who participated. It seems like there was some good participation in Jeff's chat, so I appreciate that. And I definitely appreciate those of you who have your camera on. Tomorrow, we're going to do the exam review on Zoom. So that is a change from the previous instruction. So the exam review will be on Zoom tomorrow. I will have a Kahoot game and there will be a prize. So make sure you do your studying tonight so you can win the prize tomorrow. I will stay on if you have any other questions that you want to ask. But if you did not complete the evaluations yesterday, please make sure you complete them. We give you time yesterday and today to complete them. I really value feedback. And I know Dr. Hong really values feedback. So I would appreciate if you could fill those out and let us know how we're doing. I have 40 questions on the exam and Dr. Hong has 10 questions on the exam. So that's the breakdown of it. Everything, all the topics are split evenly. I think that's all the housekeeping things. So if you don't have any questions, you're free to go fill out those evaluations. We'll see you on Zoom tomorrow for the exam review. Thank you all.